I see.
So I think the background.
I'm trying to.
It's a great background. Have you
think
gone
so?
there?
This is in Zoom.
Ah.
But I don't know how can I upload anything to as a background, but maybe this is better. What do you think?
Yeah, yeah. Have you gone to Lapland before?
Sorry?
Did you go to the north to see this?
Not yet. You know,
yet?
it's interesting because my younger brother lives in Iceland for 7 years. Actually, he is learning also the language and he wants to be a resident in Iceland. But I never been there. My preferences in temperature is really different. In weather, I mean. It's really different what you can expect in Iceland. But sometimes I have to go. The problem is that you can see the Nordic lights during the winter when the weather there is really horrible. So during summer when the weather is better, you can see the Nordic lights. But one of my or two of our friends went there right after the New Year now in January, and they saw very nice Nordic lights. And they made a presentation after returning home, and the presentation, the pictures, the images was quite impressive. And they said that yes, the weather is quite not easy to tolerate, but you know, very windy, not only cold but windy. But I think once in a life, because everybody says that Iceland is very nice in terms of nature, very special place, because actually there are no trees, but no trees. There are only very small ones, or you know, the grass and so on. But so it's a special place in world. So one time I have to visit that.
You haven't gone there before?
No,
right?
No. And neither Norway, where you can also see the Nordic lights. But sometimes I'm a little bit more Mediterranean, you know.
Hot weather is much better.
yes, and also I also like people with more temper and so on. So these Nordic countries a little bit really cold for me, but special. So one time I have to go there and I have to visit also my brother. He returned, or he come to Hungary every year 2 or 3 times, so we can meet. But it would be nice to see the island too, the Iceland. Have you ever been there?
Not in Iceland, but I went to Finland twice, I guess. And there was an AO meetings, and I haven't gone to the far north, but we were on the north side, so we had some snow exhibitions and the meeting together. But I haven't had a chance to see these Nordic lights. The most part of it, these places are really cold.
Yes.
And you said that the Iceland is windy, but also the people is also cold.
Yes.
You're correct there. I'm not, saying anything, but I had a very good friends in Finland, and they said to me that when you go to the bar, don't try to talk with the other guys because they don't like to talk.
Yes. They are closed. Yes, it's true. Anyhow, once in a life, I think we have to try it. With these Nordic lights, the problem is that even if you are in a theoretically good period in the country, maybe you can't see anything.
Yeah.
So it depends on a lot of factors. And these friends told that actually when you see the Nordic lights, these are not really yellow, blue, green, not color, a little bit, but on the photo or on the video, it's much more colorful than in life, you know? It's special and very nice, but like small shining and like when there is thunder and can I say the lightning, and you can see the lightnings all everywhere. So special sometimes, but it's not on my really on the top of my bucket list, you know.
What's the first place to go?
Oh, it's not easy because, you know, last 2 years we couldn't travel almost anywhere. But I really want to go to the Maldives once in a life, yes, because the sand and the beaches and the nature and so on. I really want to go to Africa, much more than than to Iceland, and and I also like to go to South America. Once I was in Argentina, but it was in Buenos Aires. You know, I didn't have the possibility to go to the countryside, to the pampas and so on. But there are very nice countries and also the nature, the jungle. So yes, these are maybe the first three directions where I want to go. But I don't know. You know, this year the travels started. I mean, I just returned from Zurich. There was an AO educational event, and I go to Poland in April, and in May to I don't know where. Yes, to Dresden.
Dresden.
And after that, in Las Vegas, there will be the Global Spine, and the plan is to go there. I hope nothing will change because, you know, to go to a meeting and wearing mask all time, it's not really not really good. Better than only be online, but it would be nice to have our social events get back. So I hope. I don't know.
Have you had COVID infection up to now?
Yes, I had COVID one month ago. All of my family members, we got the Omicron, I think. All of us are vaccinated, and symptoms were not really significant. They were significant, but not really severe. Actually, it was started with my boy, who is 7 months old. So
7 months old.
yes.
Oh.
So we were afraid about his health, but actually it was only some days and like a mild viral infection, nothing serious. You?
I had infection. I was going to see my son in San Francisco. So I got the PCR negative report. I went there 3 days later. I had some symptoms. I couldn't have the, check by PCR. But then later on, all the family got infected. They had the PCR test and they got positive. So I said, okay, I got I had infection, but it was okay. I mean, not really bad.
I think everybody will catch the Omicron variant.
Yeah, that's much better than having
yes,
2 years
absolutely,
ago.
absolutely.
Okay, so probably we are gonna meet with you in Dresden and Las Vegas.
I hope.
I will be there, hopefully.
Very good.
And we have a chance to talk face to face and share our knowledge. So if you are ready, you can share your screen.
Yes.
And you can start your talk about spine tumors. As you know that we have one guest every month. So you are our guests for this month, and we are really looking forward to your sharing.
Thank you very much. I'm trying to share the screen, but there is a message: host disable attendee screen sharing. Can you enable me?
Okay, I will. Just a moment.
Okay.
Can you now?
Yes.
Okay, great.
Thank you very much. So good evening. My name is Áron Lazari. I'm a spine surgeon from Budapest, Hungary. And it's my honor to be here with you and share my experience with the less invasive management of spinal metastasis. Thank you for the invitation and thank you for coming. Before the specific topic, I want to emphasize the role, the lesson, what I learned from Stefano Boriani, that surgeons who are dealing with spinal tumors are not only spine surgeons, but have to be also oncologists. And there are a rule about the management of oncological patients, and these are the oncologic principles. And we have 5 principles in the management of oncologic patients. And first one is the tissue is the issue. So the histology of the tumor is very, very important. Maybe the most important thing in the management. And that's why a biopsy in case of unknown metastasis is very important. On the other hand, the spreading of the disease, so the staging of the patients is also very important in the planning of the management, and we are using different staging systems, and we are not only focusing on the involvement of the spine, but also on the spreading of the disease in the whole body. The third principle is about the adjuvant therapies, and don't forget that there are several options to treat malignant tumors. And when you are planning the management of the spine with the metastasis, you always have to consider the role and the possibilities of the different adjuvant therapeutical options like irradiation, chemotherapy, biological targeted therapies, and so on. So that's why we need a multidisciplinary team, or we need very close contact, very close relationship with oncologists and oncoradiologists. On the other hand, there is always some toxicity of the therapy, and not only I'm talking about the adverse events of adjuvant therapies, but I'm also talking about the complications with the surgical treatment and the loss of function what can be resulted by the therapy itself. So that's why, and this is the last principle, the patient preferences should be always considered and discussed with the patient. And the modern spine oncology is not focused only on the mortality, but it's focused on the quality of life and the patient's function. Regarding the spinal mats, we can say by nature, by definition, that the surgery is a palliative surgery, and oncological treatment is very important in patients' treatment. And the surgical treatment should be focused on quality of life and the survival of the patient. And that's why when we are focusing and planning the surgical treatment of a spinal metastasis or any kind of spinal tumor, with the surgery, we have to always consider the complications, the possible complications of the surgery, of the surgical treatment, because not only the treatment itself, but the adverse events are also influence the outcome of our therapeutical approach. Here you can see a quite nice paper about the 1-year survival after surgical treatment of metastatic spinal lesions. And we can say that different factors can influence the survival of the patients. And one important factor is the ambulatory status, so the function of the patient. This figure is about the association between the patient's general performance before the surgery and the expected functional outcome after the surgery. And if you are looking on the figure, you can see that below a particular general status of the patient, we can say in poor general status, You can do any kind of surgery to treat the patient with spinal mat, but you can't improve the quality of life, you can't improve the function. This is the bottom line. On the other hand, in this paper, above Karnofsky scale 60, the spine surgery will improve significantly the quality of life, and this result can be maintained with time. Considering the latest scientific results and evidence in the literature, some algorithms were published about the management, the complex management, and the indication for surgery in spinal mats. And in my everyday practice, I use these algorithms published by a large group, and it was published in the Lancet Oncology 4 years ago. And you can say that the first consideration step is the performance status, the global performance status of the patient. And this paper, they divided the patients into 2 groups according to the global performance status, the Karnofsky scale below or above 40, and the life expectancy. And in this new or quite new algorithm, the life expectancy, if more than 2 months, you can consider the surgical treatment of the patient. But there are different other factors like the systemic burden of the disease and the possibility for the control, for the oncological control of the disease, and choosing the right answer or the individual answer right for the patient. You can go through this algorithm, and after that, if the surgery is indicated, you can use another algorithm, the MNOP algorithm, considering the mechanical, the neurological, the oncological, and the preference of the patient. This is an MNOP algorithm where the first step, and it's very important to consider the stability of the lesion, the stability of the spine. After that, you have to make assumption about the neurological consequence of the metastasis, the neurological consequence of the lesion, and after that, the responsiveness on radiological therapy. And if you consider all of these issues, you can have a lot of different options for the surgical or maybe non-surgical management of the patient. So when you plan the management of a particular patient beside the surgery, you have to consider the oncological options. You need an oncological plan. Adjuvant therapies before or after the surgery, pre-op or post-op, and also you need a rehab plan, because sometimes, unfortunately, these patients really need rehabilitation after the surgical treatment or oncological treatment. And in this case, the support from the family is also very important regarding the whole functional and functional status of the patient and the quality of life. Regarding the surgery, we have to list and consider the symptoms caused by the spinal mat, the anatomical considerations, the anatomical situation, also the biomechanics, and we have to consider not only the biomechanical changes caused by the metastasis alone, but we have to consider the post-op biomechanic or the biomechanical situation after the resection of the tumor. And we also have to make a consideration with the soft tissues, and not only because of the resection plan, but also sometimes we really need a soft tissue reconstruction involving plastic surgery, for example. So where are the urgent indications for a surgical treatment of a spinal mat? We can say that progressive myelopathy, Cauda-Equina syndrome, or a progressive radiculopathy with motor weakness are the most important or most clear indications for an urgent surgical therapy. And altogether, we can say that if the patient loses the ambulation ability because of the spinal mat, the surgery can help to improve the ambulation status. And it can be also associated with the very severe pain. So don't forget that if the patient doesn't have any severe neurological symptoms, but she or he can't walk because of the pain, the surgery should really help in the function of the patient, and maybe only the surgery can help in the improvement of the ambulation ability. So if there is this kind of indications for urgent surgery, we always have to consider not only the symptom itself, but the dynamism of the symptoms. So it's really important that, for example, the myelopathy signs developed when and how fast. On the other hand, in these cases, even in case of very severe neurological status, the surgery, what is done as soon as possible, can help in the improvement of the neurology. We are assessing the stability of the spine in the MNEOP algorithm, and for the risk assessment for spinal instability, we have a very nice and easy to use tool. This is a spinal neoplastic instability score developed by the Spine Oncology Study Group years ago, and this tool has 6 different questions, or six different domains, and all of the domains are about the lesion. And scoring these domains, you can have a SINS score and 3 categories of SINS score, and on this you have 2 potentially unstable or really unstable situation when the spine surgical consultation is really indicated. Don't forget that the SINS is not a decision-making tool. SINS is a referral tool, especially developed for radiologists, traumatologists, GPs, oncologists, to know when the spine surgical consultation is indicated and is important, preserving or improving the quality of life of the patient. The other very important issue is the spinal cord compression by the metastatic lesion. And we can say that the spinal cord compression causing myelopathy and loss of ambulation is an urgent sign is a sign for urgent indication, and the patient can really benefit for a prompt or very urgent surgery. But you have to always consider the other factors of the patient, like the general status, the need for blood, and so on. So don't focus only on the neurological status of the patient, but always focus on the whole picture. Because we have a number of complications, and the complications should be really avoided, because otherwise, with the surgery, we will cause a deterioration in the functional status, and we can also increase the mortality of spinal tumors with the surgical complications. And if there is only a mild complication, it can cause a significant delay in the oncological treatment. So we make a lot of effort to avoid any kind of complication, and because these are really the dark side of our everyday practice, and spine tumor patients, especially metastatic patients, have got an increased risk for complication because of the immune suppression, because of the decreased healing capabilities. Sometimes these patients has other diseases. The primary tumor itself in the lung, for example, can cause an immune suppressive status of the patient, or paraneoplastic syndromes. So these patient group have got really a high risk for any kind of surgical complication. That's why we try to use, or we try to apply, less invasive surgical therapies, because less invasive surgical treatment has less complication. And the first one is don't do any surgery. And in spinal mets, you always have to consider the role and the possibility for radiotherapy. And here I want to emphasize the two different types of radiotherapy, the conventional one, and here you can see the schema of the conventional radiotherapy when the target zone of the irradiation is quite big, quite large. But we have the new type of radiotherapy, the stereotactic body radiotherapy, when the oncoradiologist can really focus on the irradiation to the spinal lesion, to the vertebral lesion, and this can help to increase the irradiation dose and decrease the harmful effect of the surrounding tissues, including the spinal cord. And this concept was further developed recently by using the term of separation surgery, and the separation surgery can help to irradiate effectively the spinal tumors with significant metastatic spinal cord compression. In these cases, we are using a decompression surgery and make the spinal canal free from tumors, and it can help the oncoradiologist to make an effective and dose without harming the spinal cord. So separation surgery is a little bit different from conventional surgical therapies because actually we are prepared the patient for the effective radiotherapy with the surgery. This is an example, an old lady with a history, a long history of breast cancer. And she had breast surgeries, irradiation, local recurrence, irradiation, local recurrence, again surgery, more than 20 year of history, and it's quite frequent, quite common in breast cancer. And 1 year ago, the patient has a local back pain. On the other hand, this patient was obese with hypertension and hypothyreosis. And the cause of the back pain was thoracal 5 metastasis and also developed some small multiplex lesions as well in the skeletal system. So the oncologist decided on radiotherapy. They also got some, she also got some hormones and bisphosphonates. But actually, despite these treatments, there was some progression in the local lesion anatomically because the patient has a metastatic spinal cord compression, Bielski-1 epidural disease without any neurology. And this is important. Here you can see the picture at the time of the spine surgical consultation, and you can see that the lesion mainly coming from the posterior part, mainly coming from the lamina, invades the spinal canal, but doesn't cause myelopathy. The patient has some axial pain without neurology. Using the scenes, the scene score was 9, and it was so that's why it was a stable or potential unstable lesion at the border. And the Karnofsky scale of the patient was 70%. So we asked the onco team about the patient survival, and it was expected more than 3 months. Unfortunately, because of the previous, as a result or as a consequence of the previous irradiation, we had to say that it's a radioresistant tumor, and there was no place for any more aggressive chemotherapy. On the other hand, the patient has a very strong preference. She didn't want to paralyze because of the tumor. She wanted a surgery to decompress the spinal cord. The patient was fully informed by us repeated times, considering his age, his body shape, and his long oncological history. And finally, we did a decompression surgery, laminectomy decompression, without any major problem during the surgery. But unfortunately, on the 5th day, she had a fever, a high fever, and a positive hemoculture for Streptococcus G, and immediately penicillin therapy was introduced. But despite of that, declining status was observed, and we decided on the reoperation. And we did here you can see the pictures, simple surgical site infection can be seen on the pictures. And we did the debridement surgery, but despite of the fast steps, a septic condition developed with multi-organ failure, and unfortunately the patient died on the postoperative 10th day. On the other hand, we have another example, Rose, who was a 62-year-old female, actually a relative of me, and she had a history of lung cancer. She was a smoker, she had hypertension, and she had first some intrapulmonary lesions, but at the time of the lung cancer diagnosis, she had a lesion at thoracal 8 vertebra, without any symptom, without spinal pain, without neurological deficit. And that time she had excellent performance status. Lung surgery was indicated, histology was adenocarcinoma, and chemotherapy was introduced. And here you can see the pictures about the spinal lesions, and you can see that not only one, but several or more lesions can be observed in spine. And after 1 year, we controlled this patient regularly, and after 1 year, despite she didn't have any pain, she didn't have any neurology, and she had a good pulmonary local control, but she had a progression, an epidural Bilski-1 progression in the thoracal 8. And that time, because of the chemo, because of the disease, the patient had a little more or less Karnofsky performance scale. But and that time we decided on not to do any surgery, but try to have a local control using SBRT radiotherapy. And here you can see that it was quite successful. You can see the shrink of the epidural progression. On the other hand, some spreading of the tumor was observed, but the patient was also in good shape. And that time, an immune therapy was introduced by the oncologist. And after 2 years, from the initial diagnosis, she progradiated the first spinal pain, but it was a low back pain without a neurology. And we observed lumbar metastasis, and this metastasis caused some pain. And unfortunately, she had some serious side effects, adverse events, because of the immune therapy, and the Karnofsky scale continuously declined. But that time she was also in quite good shape. So an irradiation again to the lumbar force was indicated and done, and it controlled the pain. But unfortunately, the patient status deteriorated continuously, and 2 months later, she had a sudden died because of a pulmonary embolism. But altogether, we can say that even in an advanced stage lung cancer with spinal met, she had more than 2 years survival and 2 years in excellent, good quality of life without doing any surgery. So you have to always consider the really need of surgery or the indication of the surgery. If the surgery is indicated, we have a growing body of evidence supporting the less invasive and minimal invasive MIS techniques in the management of spinal mets. And there are more and more papers supporting the use of MIS techniques. There are also some nice reviews and recommendations in the literature. What kind of MIS techniques are available in general? We have techniques for the local control. These are MIS tumor resections, or you can also use the radiofrequency ablation for the local control. It's a percutaneous technique. And we have also minimal invasive option for the stabilization from the vertebral augmentations to the percutaneous screwing and rods. But always also don't forget that these surgical techniques can be completed with radiotherapy postoperatively to have the best local control. And again, the types of the radiotherapy and the use on the concept of separation surgery. And this is another case, a 58-year-old female who had a history of lung cancer more than 1.5 years. And after the lung surgery, she didn't get any adjuvant therapy. But 1 year later, 1 year after the lung surgery, she had some elevated serum tumor markers, and she also had on the chest CT some micronodules in the lungs. And at the same time, she had progradiating back pain. And when the patient was referred to us, actually she was unable to load without neurological deficit. And here you can see the morphology, and there was a pathological fracture caused by a spinal mat at thoracal 12. Below that, in lumbar 1 vertebrae, you can see smaller lesions, but there wasn't any epidural disease. Using the scenes, here you can see the CT image, a nice lytic lesion, and using the scenes, we calculated that the scene score was 12, which is actually an unstable lesion. Regarding the biology of the tumor, we knew that from the lung surgery that this is an adenocarcinoma, which is EGFR positive. So the epidermal growth factor receptor was expressed on the tumor cells. The symptoms were severe local mechanical pain without neurology, and the patient was really motivated and in good global status. So what is the management in this case? The EGFR positivity can give us or give the oncologist the possibility to introduce biological therapy targeted the EGFR, and it can be very effective, not only at the local but the systemic control in the disease. So we had to focus on the spine and the stability of the spine. And actually, maybe this was the first patient where we introduced the percutaneous stabilization, and it was quite a short surgery without any complication and resulting in immediate pain relief. And if you can see the 2-year follow-up pictures, you can see that the construct was stable with some calcification of the tumor or of the mets, thanks to the oncological therapy, and the patient has excellent quality of life without any progression of the disease. Here is another example of combined therapeutical options, and it was a quite difficult case regarding the patient's immune status, because this patient has a chronic hepatitis. Decades ago, she had a liver transplantation and diabetes, and she had an immune suppression because of after the transplantation. But unfortunately, she had a quite severe mechanical low back pain, and you can see this lesion at L3, and the biopsy of the lesion proved hepatocellular carcinoma met at L3. It's not a quite favorable biopsy result, histology, especially if the patient is in immune suppression. But on the other hand, the patient has very good global performance status. Only the pain was the problem. So we decided on doing a radiofrequency ablation of the mass, of the tumor mass, to have some local control effect, and a percutaneous stabilization, a short construct. And what I can say that this surgical therapy proved an excellent quality of life and a stable disease for 2 years. After that, some epidural spreading appeared on the control images. Quite often, histology is the renal cell carcinoma met in spine. And unfortunately, you will know that this kind of tumor is really vascularized. So the blood loss of an open surgery can be huge, especially if we cannot do any kind of preoperative embolization. This patient it's a male and without any significant medical history. he had a tibia pathological fracture 6 months ago, and unfortunately that time from the pathological tibia fracture there wasn't done a histology. On the other hand, later he developed low back pain, and this pain was really progressive, causing a sudden deterioration, and combined with left leg pain, and the cause of that was renal cell carcinoma metastasis at L3. You can see the huge met at L3, and that time we decided on a quite urgent surgery because of the patient's loss of ambulation, and we did a first percutaneous stabilization with a long construct, and after that, or at the same time, I mean, we made a mini open decompression focusing on the nerve root, on the L3 nerve root. We didn't have any complication, and the patient had immediate pain relief, and quite short length of hospital stay after this percutaneous treatment, and the patient started the adjuvant oncological treatment, the biological therapy for renal cell carcinoma. This was a Sutent therapy, and we have 3-year follow-up data. You can see the wound healing, and you can see the stability of the construct, even that we know that the patient that there is tumor at L3, but the patient live with the evidence of the disease, but with quite good local control and excellent function. There is also another option to be less invasive. Not only the percutaneous procedures are less invasive, but if you can make your open surgery less invasive, you can help the patient to avoid complications. For example, this is a quite young lady with a more than 5-year history of breast cancer. And first the cancer attacked the left breast. After that, unfortunately, later the right side was also infected, and at that time the metastasis at L4 was diagnosed but didn't cause any problem. Unfortunately, some years later, she developed sciatic pain without any neurology, and also some low back pain. And you can see that the L4 at L4 level, the metastasis had some epidural progression despite the previous irradiation and chemotherapy. And in this case, we decided on that was the only known spinal mat, but because of the previous irradiation and chemotherapy, we decided on a aggressive management. I mean that we try to to reduce the tumor mass in the patient by resecting almost all vertebrae. So a corpectomy was done, but it was a planned subtotal corpectomy, and but we had to apply an anterior support. And here you can see an anterior support when we are using PMMA. So a big PMMA spacer is introduced to support the anterior column, and there are 2 main advantages, or three. First, that the PMMA is moldable when you are applying that. So there is no need for example, for nerve root resection to insert a large cage into for example, especially at the lumbar part. Next advantage that you can put implant screws into the PMMA mass during the molding or hardening process. So the construct can be very strong itself, and that's why we were able to apply a short construct even in case of a quite large instability caused by the corpectomy. And the third one is that PMMA can be irradiated. So here you can see that above and below one vertebrae was stabilized by titanium screws, but in the PMMA we inserted carbon screws, and after that the patient got an SBRT therapy, and here you can see that the construct is stable and the disease is controlled, and the patient has excellent function. So sometimes you can decrease the morbidity of the surgery, the invasivity of the surgery, using shorter construct, shorter but stable construct. And this is another example of that, where the patient's advanced stage of lung cancer metastatized first the L4 vertebral body, and that time we made a decompression of the nerve root, but some months later the patient had symptoms and severe symptoms because of thoracal 1 metastasis with Bilski 1 epidural compression. And it was not an easy situation, because here you can see that the tumor has progression not only to the epidural space, but also to the mediastinum. And we discussed the situation with the oncologist, and the oncologist asked us to remove as much tumor as we can without severe complications, because after that irradiation was planned. So we made a thoracal 1 subtotal corpectomy, and using again the PMMA spacer, the PMMA corpectomy replacement with screws into the PMMA. But unfortunately, despite of irradiation and immune therapy, the patient has not only local progression. You can see the ventral mass grew. The spinal cord is free and the canal is free, but unfortunately the patient has a systemic progression too, despite that we have an acceptable quality of life, and it means a significant issue for the patient, even if she is in the last months of her life. So summarizing, my take-home messages are that always think in complex management, even in the case of most simple tumor or most simple math. You have always considered the oncologic principles, and always consider the patient's quality of life and the possibility for oncological treatments. And our management is focused on the patient's quality of life, but to improve the quality of life, one issue is to avoid complications of the surgery. And maybe one of the best tools to avoid surgical complication is to learn and apply the minimal invasive methods in the surgical management. Thank you very much for your attention, and I'm open for questions.
Thank you very much, Aaron. It was a great talk, and you show us very good examples of being minimally invasive. If any one of our friends would like to ask any question, you can write down and I can ask it from here to Aaron. Other than that, can I ask you one question about
Sure.
having a biopsy for metastasis? Is there any specific conditions of that you don't take a biopsy and you...
Sure. If the patient has a quite short history of disease, the primary tumor is well known, for example, a lung cancer, and he or she developed the metastasis in 3-6 months after the primary diagnosis, we don't need the biopsy, because 99% the tumor is coming from the recently diagnosed primary tumor. On the other hand, there are patients with a history of different types of malignancies. We have patients with 3 different malignant primary tumors in the medical history: breast, colon, and prostate, for example. And sometimes the oncologist itself is asking for biopsy because she can, the oncologist, he or she can set the oncological therapy based on the molecular profile of the spinal mat. So sometimes the molecular profile of and that's why the subtype of the metastasis is different from the previously diagnosed primary tumor, and the oncological therapy should be changed. And this is an information for the oncologist. So sometimes we do the spinal biopsy without any other surgical step, only to have this information about the possible changes in the molecular profile.
So maybe the second question will be about vertebroplasty.
Yeah.
What do you think about using vertebroplasty? Does it make a complication of progressing the tumor cells to the backside of the vertebra and compressing the spinal cord?
Yes. There is a risk for these adverse events or adverse consequences of after vertebroplasty. So in my personal experience, I only do vertebroplasty if there is significant and good systemic therapy for the tumor. So without that, it can be risky. I mean the spreading of the tumor cells. And I'm sorry, what was the spinal cord compression?
You know, when you think about the corpus, you put the cement.
Yes.
And then some of the cells is couldn't
coming
find
out.
Coming out.
Yeah.
Mostly to the backside.
Yes. Based on the anatomy, it can happen. So let me tell you that actually I don't remember when I did last time vertebroplasty alone for a tumor, for a spinal mat. The situation is different with myeloma cases, but in myeloma multiplex, actually, if there is a good option for adjuvant therapy, the patient in brace can be stabilized for 1 or 2 months, and the adjuvant therapy can help very fastly in the stabilization of the spine. So I think the real indication for doing vertebroplasty alone is less and less.
Okay. So maybe the last question from me, how often do you use the radioablation?
Rarely, and this is also a cost issue, unfortunately.
Okay.
On the other hand, we did some case, it's not real science, I mean that we never published them because it was only 1 or 2 cases, when we planned an en bloc or a subtotal corpectomy, but before that, we applied the radiofrequency ablation in the vertebral body, and we sent the specimen to the histologist to see the effect of the radiotherapy. And actually, radiofrequency ablation can really cause a huge necrosis in the tumor, but none of the oncologists say that it kills all the tumor cells. So it's also an option for the local control, and I think it's quite safe. So if you use that according or following the principles or the methods, but it's also because in Hungary it's quite the probes are quite expensive.
So I have a question from one of our audience, Mr. Wilbert. He's asking about, I couldn't understand, but I will ask to you, whether nuclear medical therapy is better than radiotherapy in metastatic tumor.
I don't know what he's meaning on nuclear therapy. What do you think? Nuclear?
Maybe it's about using the treatment for thyroid, maybe.
Yes. I have very limited experience, but in general, a good SBRT stereotactic radiotherapy is very, very good for local control. So even in case of conventionally radio-resistant tumors, with a good oncoradiologist and SBRT, you can make a real difference in the local control.
Okay, then you bring the last, this is the last real last question. So how often do you do the en bloc vertebrectomy for renal cell?
Previously, I mean 10 years ago, we did more. But in the era of Sutent and SBRT, we do, I don't, actually we had a patient some months ago when we really planned to do an en bloc. And, but finally, unfortunately, the vertebral body was removed in 2 pieces. But I was happy also with that, because with in the era of this kind of new oncological therapies, the key is the oncological therapy in the survival and not the removing of everything. On the other hand, for example, that time, the embolization, the pre-op embolization was excellent. So we didn't have actually any bleeding from the tumor. And if you don't have good embolization, sometimes the en bloc resection of the mass is safer because of the bleeding. So you can control the bleeding better if you can remove the mass en bloc than intralesional. But very rarely. We do that very rarely.
So, well, we have one more question. Have you observed any sign of sclerosis following ablation, as it may happen following radiotherapy?
Yes, I observed that one time. It was a patient, as I remember, with a metastasis in the sacrum, and caused by or the maybe breast or ovarian cancer, and the patient was treated in Germany. And 1 or 2 years after the radiofrequency ablation, on the CTs there was a real sclerotic signs in the but I don't know. It means that there is no viable tumor cells, or maybe the appearance and the biology changed, or of the tumor changed thanks to the radiotherapy.
Okay. Well, it was a very nice presentation, and I would like to thank you again to you. You're giving your time to us.
I thank you the invitation.
So also the audience being together with us, and hope to see you in Dresden.
I hope.
Okay.
I hope. Thank you very much. Thank you.
Bye-bye.
Good night. Bye-bye.
Bye-bye.